I'd like to call the Joint Commission on Joint Audit and Review Commission to order. We have most of our members here, and I'm very grateful for you coming at this extremely busy time of year. And I'll tell you, those who aren't here have very good reasons, so it's very nice to see you. And Hal, if you'd like to do an overview of the agenda.
Thank you, Madam Chair and members of the Commission. I'm Hal Greer, the Staff Director of JLARC. As is typically the case in December, we have a very full agenda, but we'll make every effort to move through our presentations expeditiously. We'll first present the findings from our review of the CSB system. Next, we'll provide an update on our SOQ funding formula study. We'll then present the findings from our review of dual enrollment costs. We'll provide you with a requested update on VEC's progress in addressing the backlogs and other challenges that they have faced. And then we'll finish this morning with a very brief presentation on 4 areas of ongoing oversight. Madam Chair, our first presentation this morning is on the findings from our review of community services boards. Based on our research, the CSB system structure in Virginia is sound and doesn't need to be fundamentally changed. And CSB leaders and their staff throughout the state are highly committed to the extremely challenging work of effectively serving Virginians who need behavioral health services. However, our review has revealed that there are core functions for which at least some CSBs are not fully meeting expectations or responsibilities. But as concerning is how little the state knows about CSB performance and how minimal the state's performance expectations for CSBs are. This report has a number of recommendations to strengthen state oversight and accountability of the CSBs by requiring the establishment of clear, precise, and meaningful expectations for performance, and requiring CSBs to report meaningful data on performance. Improved performance data will better inform state funding decisions regarding the CSB system going forward. But it's clear from our review that additional funding is needed now to address current challenges, and the report identifies some of those areas of need. You'll hear this morning our recommendations for increasing capacity for providing crisis services. It's encouraging to hear that one of the governor's budget priorities will be additional funding to further build out services. Investing in services like mobile crisis teams that help respond to and stabilize individuals in their communities is important, and the General Assembly has made this an investment priority in recent years. These past investments should be maintained. However, we believe that the highest priority for additional investment now is in more intensive crisis services at the other end of the continuum. This morning's presentation will discuss the basis for our conclusion. Madam Chair, one final point is that you'll hear this morning that CSBs play a significant role in admission and discharge of patients from the state psychiatric hospitals. And as you know, there are many concerns currently around the state hospital system. The study that this commission directed last month to review the state hospital system in the coming year will enable us to conduct a much more in-depth review on many of the issues related to hospitals that we will touch on today. I'd like to thank Commissioner Smith and his staff at DBHDS for their assistance and cooperation in conducting the review. We would also like to thank the executive directors of the CSBs and their staff for their willingness to meet with us and provide us with extensive input for this review, as well as the leadership in the state hospitals who were generous with their time. Tracy Smith oversaw the review, and Drew Dickinson was the project leader. I'd like to introduce Drew now. Drew?
Good morning, Madam Chair, members of the Commission. As Hal mentioned, my name is Drew Dickinson, and I led our review of CSB Behavioral Health Services. The resolution for the study directed us to review various aspects of CSB Behavioral Health Services. Some of the items we were asked to review are listed on this slide. The next slide summarizes some of our key research activities, which include data analyses, 2 surveys, and around 90 interviews. More information about our team's methods are included in Appendix B of the final report. Our study found that a fundamental restructuring of the CSB system is not necessary, but that improvements are needed. Compared to a decade ago, CSBs are serving more Virginians with serious mental illness, and individuals with significant impairments tend to improve their functioning while receiving CSB behavioral health services. CSBs struggle to hire and retain staff, especially for emergency and crisis services, and turnover among CSB staff is high and increasing. We also found that CSBs recommend psychiatric hospitalization for some individuals who do not need that level or type of care. And expanding residential crisis stabilization units would help reduce inappropriate state psychiatric hospitalizations. DBHDS does not adequately oversee the performance of CSBs, and CSB's Medicaid funding has declined. Some CSBs are not consistently billing Medicaid or successfully receiving reimbursements from MCOs. In the interest of time, I won't cover the Medicaid funding topic in this briefing, but if you're interested in learning more about CSB Medicaid funding and what could be done to increase reimbursements, you can find our findings and recommendations in Chapter 5 of the report. I'd like to start off by giving you some high-level background on CSB behavioral health services. CSBs are the public provider of community-based behavioral health services. They provide behavioral health services to adults and youth with serious conditions, including those with significant functional impairments and those who may be an imminent risk to themselves or others. Importantly, CSBs are only one type of provider in Virginia's broader publicly funded community behavioral health care system. In fact, 82% of Medicaid behavioral health spending in fiscal year 2021 was paid to private providers. CSBs provide both emergency and non-emergency services to individuals with mental illness or substance use disorder. The slide lists some of the examples of emergency and non-emergency services provided by CSBs. And before leaving this slide, I should also mention that CSBs also provide services for individuals with developmental and intellectual disabilities. The focus of our study was on the behavioral health services provided by CSBs. CSBs are local entities, and state law requires that every city or county establish or join a CSB. Currently, there are 40 CSBs in Virginia, and most serve multiple localities. All CSBs work regionally with other CSBs to provide certain services. And this slide just shows the 5 DBHDS regions that the CSBs are organized into. It also lists the names of the CSBs under each region. In Appendix F of the final report, we have a map labeling each CSB's catchment area if you're interested in knowing where each is. Most funding for CSB behavioral health services comes from non-Medicaid state general funds, local funds, and Medicaid fees. In fiscal year 2022, the CSB system received about $1.1 billion through all funding sources. As part of our study, we were asked to review the structure of the CSB system. Based on our conversations with national experts, available national data, and reviews of other states' models, there's no compelling evidence of a need to fundamentally change the CSB system structure. States' approaches vary, but Virginia's approach, which involves local government and service delivery, is similar to approaches used in other states. However, as we identified throughout the report, there are some improvements that are needed to the current CSB system to help ensure that it's as efficient, effective, and accountable as possible. Madam Chair, I'll pause here in case there are any questions from any members.
Are there questions?
In the next section, I'll very briefly summarize some of our key findings related to behavioral health trends in Virginia and CSB consumer outcomes. You'll find more information on both topics in Chapter 2. As I mentioned earlier, CSB behavioral health services are primarily intended to help individuals with functional impairments related to their condition. Impairments could include an inability to work, maintain housing or healthy relationships, or care for themselves. When a mental illness significantly impairs an individual's functioning, it is considered a serious mental illness. For some context, the prevalence of mental illness is increasing in Virginia, and this follows national trends. The prevalence of serious mental illness has also increased over the past decade, and this also follows national trends. The report notes that CSBs are serving more consumers with a serious mental illness than they were a decade ago. Individuals with serious mental illness generally require more intensive and longer-lasting services. Mental health and substance use services are generally intended to help individuals manage or overcome functional impairments. So our team analyzed recent data on CSB behavioral health consumers' functioning levels. We found that CSB consumers with the most severe impairments tend to improve their functioning while receiving CSB behavioral health services. Since 2019, CSBs have been required to assess the functioning levels of consumers periodically, and the functional assessment is called the DLA-20. The DLA-20 assessment is used by public and private providers in other states as well. This table summarizes the different functioning levels and generally how to interpret each level. We looked at DLA-20 scores among those who are initially assessed at each functioning level and found that after at least 6 months, a majority of CSB consumers with the most impaired functioning improved while receiving services. I emphasize this first because they are a priority population for CSBs. And these consumers are among the most likely to not be able to remain in their communities. Individuals who had moderate or mild impairments were more likely to see either no change in functioning or a decline. These patterns were generally consistent across CSBs. However, data limitations prevent determining with certainty the extent to which CSB services are responsible for changes in consumers' functioning. In Chapter 2, we have a recommendation that would help DBHDS and policymakers understand more about consumer functioning levels and the effects of CSB services. Because this data provides among the most helpful information that we've seen on CSB performance, we have a recommendation for DBHDS to report annually on CSB performance on improving consumer functioning levels. Madam Chair, I'll pause here again in case there are any questions.
Don't see any.
Thank you. I'll now turn to our findings related to staffing for CSB behavioral health services. If you're interested in this topic and our recommendations, you'll find more information in Chapter 3 of the report. We found that turnover among CSB behavioral health staff is high and increasing, and that CSBs struggle to hire new staff. In interviews and survey responses, CSB executive directors report substantial difficulties retaining staff, particularly staff providing emergency and crisis services. About a third of CSB emergency services staff reported that they were considering leaving in the next 12 months. Almost all CSB executive directors reported substantial challenges recruiting qualified staff for behavioral health services. Using VRS data, we found that at least 16 CSBs have lost an average of 20 to 30% of staff per year recently. Between fiscal years 2020 and 2022, the average annual turnover rate among the 23 CSBs for which data was available was 20%. For a point of comparison, the state employee workforce turnover rate in fiscal year 2021 was 12%. Turnover rates among CSB staff have increased over the past decade, and there was a sharp increase in turnover in the most recent fiscal year. I should note that the highest turnover and vacancy rates were in direct care positions rather than administrative positions. Chapter 3 details some of the impacts of these staffing challenges, including an inability of most CSBs to provide same-day assessments to all consumers on the same day that they're sought, and challenges implementing crisis services. They are also contributing to long wait times for services at some CSBs. Our team collected wait times data from CSBs that track them and found that consumers at some CSBs are waiting a long time before receiving treatment. This slide shows an example of average wait times for consumers who are determined to need mental health outpatient therapy. We present wait times data for other services on page 31 of the report. We found that uncompetitive salaries are a key reason for CSB staffing challenges. For some context, in Virginia and nationally, data indicate that there are not enough behavioral health providers to meet demand. Virginia's behavioral health workforce appears to be increasing, and a greater proportion of licensed providers are opting to work in the private sector. In contrast, a smaller proportion are opting to work for state and local governments. This means that CSB clinicians have more opportunities to work elsewhere, and CSBs are increasingly competing with other establishments to recruit and retain qualified staff for behavioral health services. One of the most common reasons for turnover that was cited by both CSB executive directors and CSB staff was compensation. For example, 59% of CSB emergency services staff who were considering leaving for their job were planning to leave because they believed other employers offered better compensation. Although comparison data is very limited, we were able to compare CSB pay for licensed behavioral health clinicians to the pay of other licensed behavioral health clinicians in Virginia. This figure shows the average annual wages of CSB licensed clinicians across CSBs. This bar is the median estimated annual wages of all Virginia licensed professional counselors and licensed clinical social workers in Virginia, according to data from the Department of Health Professions. JLARC staff typically consider our competitive range to be 10% above and below the market median. Using this data, we found that a majority of CSBs pay licensed behavioral health clinicians less than competitive salaries. We recommend the General Assembly consider including funding in the Appropriation Act for a salary increase for direct care staff at CSBs. We also recommend requiring DBHDS to report annually on turnover, vacancy rates, and salaries across CSBs to monitor workforce challenges. Before leaving the staffing section, I also wanted to mention that burdensome administrative requirements are also a key reason why CSB staff are leaving. Several recommendations in our report would help alleviate the administrative burdens on direct care staff. If you're interested, our findings and recommendations related to administrative burdens can be found in Chapter 3. Madam Chair, I'll pause here again in case there are any questions.
Yes, Delegate Torian.
Yes, just real quickly, can you give us an example of what are some of the administrative burdens that you referenced, please?
Sure. There's, we talk about it in the report, but for example, DBHDS has 10 different systems through which CSBs are required to report information. And in some cases, the CSB clinicians are required to actually input data for those. There's also some requirements that are from DBHDS licensing staff and then a different program office area staff that conflict, but they have to do both of them. And so we feel like DBHDS could have and we have a recommendation specifically for DBHDS to take the lead on this, but just to identify all of those burdens that are currently on CSB staff, and then which ones need to be there, which ones could be taken away. Just make those decisions. And so really freeing up time for staff who are we're seeing these staffing constraints generally. We want to make sure we're able to use them as well as we can.
Okay. Anyone else? Yes, Dr. Wick.
Thank you, Madam Chair. You mentioned including funding in the Appropriations Act for direct care staff to make that pay more competitive. I didn't see a number. Do you have a number?
Delegate Ware, we have an estimate in the report for that, how much that would be. But it depends on what proportion of the salaries that the General Assembly wishes to pay. But we can certainly, if you need more information on that, we're happy to do that.
One related
Yes,
question. Thank you.
Ware.
Thank you. I take it there are a couple of, one of the options would be to do it incrementally over a course of several years, and one would be to do it all together. And I see you flipping through some pages there. Are you coming up with a?
Yes. So we estimate that for a 5% salary increase to all CSB staff would be $11 million to $34 million. But if it's just to behavioral health direct care staff, the 5%, it would range from $6.7 million if 30% of total costs were covered to $22.3 million if 100% were covered. So that's in a single fiscal year.
Thank you very much.
Sure. Thank you.
Thank you, Madam Chair. So on the slide number 30, the competitive salaries page, forgive me for not completely understanding that. So as I look at it, I mean, you're listing the median estimated annual wages of all those, the LPCs, so forth. Where on there are the number you use for the Community Services Board, where do they fall on that graph?
Delegate Wilt, good question. So the bars, the individual bars on this represent each CSB and how much they pay their licensed clinicians on average. And so, does that answer your question?
Madam Chair?
Yes.
Okay, so where's the bar that you're comparing to? How do we know that's good or bad or?
So that's this bar right there, Delegate Wilt. That bar is across all Virginia LPCs and LCSWs, what they report earning each year related to their behavioral health work. So that would be statewide what we're seeing being reported by all, not just those working at CSBs, but everywhere. And so we put that up there, and then the competitive range here just is relative to that.
Further questions? Okay.
All right. Madam Chair, I'll now briefly summarize some of our findings and recommendations related to CSB emergency services. If you're interested, you'll find much more detail in Chapter 4. CSBs play a critical role in state psychiatric hospital utilization, and CSBs are required to conduct pre-admission screenings to determine whether individuals who are experiencing a behavioral health crisis need to be admitted to an inpatient psychiatric facility, such as the state psychiatric hospital. CSB emergency services staff can recommend the individual be placed under a temporary detention order, or TDO, if needed, and are required to find an appropriate facility for individuals who need inpatient treatment. As you know, state psychiatric hospitals have been operating at or near capacity and have wait lists. In some cases, the waits for admissions are extensive, particularly for children and adolescents. The lack of available beds has reportedly been resulting in some individuals not receiving treatment in a timely manner or at all. For example, various stakeholders reported that the lack of inpatient psychiatric beds have led to individuals being detained in emergency departments for long periods without receiving needed psychiatric treatment, and individuals being released from emergency departments at the expiration of their TDO without receiving any psychiatric treatment, despite recently being determined to be an imminent threat to themselves or others. Situations like these underscore the importance of ensuring that inpatient psychiatric hospitalizations are reserved for only those who need the most intensive psychiatric treatment and for whom no feasible alternative treatment options are available. We found that CSBs recommend state hospital TDO admissions for some individuals who do not need that level or type of care. We interviewed leadership and staff at state psychiatric hospitals, and they estimated that 20 to 50% of their civil TDO admissions did not need to be placed at their facility. Similarly, CSB emergency services staff reported a substantial portion of individuals, particularly children and adolescents, who they recommended for psychiatric hospitalization and who would have been better served in a less restrictive setting had one been available. Although factors both within and outside the CSB's control affect whether someone is recommended for hospitalization, we wanted to look first at what was within the control of the CSBs. We analyzed variation in the proportion of pre-admission screening evaluations resulting in a TDO and found that there is significant variation across CSBs. While a number of factors can contribute to this variation, it indicates possible inconsistencies in screening practices and TDO recommendations across CSBs. CSB clinician qualifications are generally similar to those in other states, but we found that gaps in training for CSB staff likely contribute to some inappropriate hospitalizations. 40% of surveyed CSB pre-admission screening clinicians felt that additional training would be beneficial. And we have a recommendation that would provide CSB's clinicians greater access to quality training. We also identified a need for better oversight by DBHDS to ensure effective pre-admission screenings are being conducted and that the resulting recommendations are well supported. DBHDS has recently initiated additional oversight activities in this area, and we have a recommendation to ensure that it fully develops these capabilities. We also found that a lack of alternative placement contributes to inappropriate state hospital TDO admissions. We go into more detail on this topic in Chapter 4 of the report, but one type of placement I think is worth highlighting are residential crisis stabilization units. CSBs offer various types of crisis services, including assessment, non-residential treatment, and residential treatment services. We have an appendix in the report that is intended to help clarify the different types of crisis services and how they relate to each other. One thing that I'd point out is that most new state funding over the past decade has been for assessments and relatively low intensity treatment. We found that residential crisis stabilization units, or RCSUs, would more directly help alleviate state hospital admissions than other types of crisis services. Although other services would likely help to some degree, RCSUs can be equipped to provide short-term residential treatment to individuals under a temporary detention order. And a substantial portion of individuals who are admitted to state psychiatric hospitals have short stays. They can also provide a step-down option for state hospitals. We used national benchmarks and found that Virginia needs roughly twice as many RCSU beds than are currently available. And they are most needed for children and adolescents and in Southside Virginia. There are some RCSUs that already exist but are not operational or are operating under capacity because of staffing challenges. Our team visited a new RCSU in Southwest Virginia that is not operational due to staffing challenges. In the short term, we recommend the General Assembly consider including funding in the Appropriation Act to help CSBs hire additional staff for RCSUs whose bed capacity is not fully utilized because of a lack of staff. In the longer term, we recommend additional funding be appropriated to support the development and operations of additional RCSUs for children and adolescents and for underserved areas of the state, including the South Side. We also found that the state's current psychiatric bed registry wastes limited time and staff resources. Pre-admission screening clinicians have only 8 hours to conduct a pre-admission screening evaluation and to find a bed for someone who needs to be placed under a TDO. DBHDS's bed registry is intended to help improve the efficiency of the bed search process, but it lacks real-time, useful information about bed availability. We checked the bed registry in June, and it showed that 13 of the 25 facilities listed had not updated their bed availability in at least 2 days, and some had not updated their availability in months. Because of these deficiencies, CSB staff still end up calling and physically faxing individual hospitals directly. We have some information in the report on other states' approaches to improving the efficiency and transparency of their bed search processes, and note that comprehensive improvements to Virginia system will take some time. In the near term, though, the state should contract for a system for clinicians to securely send documents to inpatient facilities electronically and suspend the requirement that the bed registry be used. Slide 47 just summarizes those recommendations. Madam Chair, I'll pause here again in case there are any questions.
Senator McPike and then Senator Norman.
Thank you, Madam Chair. My question is in relation to the bed registry and the efficiency. Obviously, the bed registry was created for a very important resources, which is in past examples, some tragedies that happened. The point is to identify those resources and make them available. Can you speak more to what it is that would be able to better identify how to make those resources available so we don't miss out on prior mistakes and lessons learned?
Senator Pike, it's a good question. So one of the biggest deficiencies of the bed registry, well, two things, is that it doesn't provide timely information, which is critical. It also doesn't provide useful information. So providing systems that provide more of that, we have some examples of other states that in the report that have referral systems. It's a little bit more comprehensive than just the bed registry to make that information more available. But at this time, we feel like something that can help CSB staff not have to physically fax documents to 20, 30 hospitals is warranted at short term. But we're actually going to be looking at that next year in a state psychiatric hospital study, really going in depth to help make sure that we're doing that right and we can set ourselves up well in that area.
Senator Norman.
Thank you, Madam Chairman. What can we do to incentivize hospitals and CSBs to update this and not allow it to continue to languish?
Senator Norman, good question. We'll be looking at that in more detail next year in the study of state psychiatric hospital. But I will say one important thing we'll be having someone at DBHDS actually paying attention to seeing that what is required of these inpatient facilities, that they are actually doing this. So making sure we're having attention and not letting this persist.
Madam Chairman, I appreciate the workload that you and your team has, but I don't get warm fuzzies realizing we're going to let this languish for another year.
Senator, I think we would wholeheartedly agree with you. We do have a recommendation that in the interim, there needs to be something that DBHDS pursues immediately that does allow CSBs to essentially fulfill the function of the bed registry more efficiently than it can right now. And we do think that's possible. Right now, requiring them, though, to use the bed registry, requiring the hospitals to participate in it, that actually hasn't been effective. One of the reasons why the information is not relevant, updated, and useful to CSBs is that even though all hospitals are required in code to participate, they don't. And so sort of the short-term immediate solution is to come up with a data exchange system that essentially the CSBs can use with the hospitals to send that information to get the beds as quickly as possible. Right now, their workaround, as Drew said, is faxing and calling. They only have 8 hours to do that. And in that time period, when you're getting to the point where the ECO could expire, that really does create a risk for the community and for those individuals. And so we fully appreciate that this needs to be fixed and that time is of the essence. We do think in the details in our report and in the recommendation, we have a path forward for DBHDS, but it is not revamping the existing bed registry. We do think that should be discontinued.
And Senator Norman, I would also add that I was just looking at the CSB emergency services staff, their responses relating to this topic, and they are asking for, there's many of them just saying, help us not have to do the physical faxing. And so just looking at that this morning. So that is going to be an important fix short term, but I agree that we need something better and it needs to be done soon. So.
Okay.
Thank you, Madam Chair. In my last section, I'd like to briefly summarize some of our key findings and recommendations related to state oversight of CSB performance. A common finding across prior studies of the CSB system is that there is a lack of meaningful accountability. This does not mean that CSBs do not have oversight. As we mentioned, CSBs are subject to a lot of oversight, but almost none of it helps understand how CSBs are performing and how consumers are faring. Effective accountability through state oversight is generally more challenging in state-supervised, locally administered systems. But this accountability is particularly difficult without clear direction, relevant information on performance, and effective accountability mechanisms. We found that DBHDS's oversight of CSB performance is hindered by inadequate performance contracts and data systems. DBHDS is required to enter into performance contract with each CSB that receives state funding. They contain performance measures, but few of them are useful. We recommend a comprehensive reevaluation by DBHDS of the performance contracts, including improvements to performance measures. DBHDS's data systems are also not compatible with CSB data systems, which complicates reporting and data analysis, and as I mentioned, adds to administrative burdens on CSB direct care staff. DBHDS is in the process of improving its data systems, but the initiative is very complex. We have a recommendation in the report for DBHDS to provide periodic updates to the General Assembly on the status of the initiative. Going forward, DBHDS needs to devote more attention to CSB performance. State law currently allows, but does not require DBHDS to conduct ongoing performance monitoring of CSBs. And until recently, DBHDS had only one staff position devoted full-time to managing contracts for all 40 CSBs. This problem is not new. Reports dating back to the 1970s have identified significant gaps in DBHDS's monitoring efforts. We have several recommendations in the report to help improve DBHDS's performance monitoring, and two of those recommendations are listed on this slide. And the next couple slides just summarize our key findings again. In the interest of time, I won't read through them. And that concludes my prepared remarks, Madam Chair. I'll be happy to take any questions that any members may have at this time.
Any further questions? Yes, Delegate Carr.
Thank you, Madam Chairman. Going back to slide 16, and just, having more mental health cases, is there any instance of there just being more diagnosis happening today than there were in previous years?
Delegate Carr, it's a good question. We looked at that, and there does seem to be the increases may be attributable to people being more willing to seek treatment and getting that diagnosis. But there are some indications, and we provide some examples in the report, of actual prevalence going up and indications that there are some really serious issues going on.
Thank you. Thank you, Madam Chairman.
Further questions?
Madam Chair.
Yes, Senator McPike.
Thank you, Madam Chair. Could you speak to the relationship of Medicaid reimbursement and billing for the CSBs, and also the complexity of, I guess, our CSBs trying to get reimbursed through our MCOs, through, I mean, we've got like multiple parties that are theoretically all working for the Commonwealth. And sort of the lack of billing and who's doing well, what do we need to do there? Because there's a lot of money left on the table. There's sort of cogs in the process as well, it seems like. Can you help us clear that up in 30 seconds?
Sure, Senator
That's a joke.
So I'll say Chapter 5 that's what we focused on, Medicaid funding. It is an important payer source. It should be used first so that state general, non-Medicaid state general funds can be used for other consumers. We have concerns that break down in two categories. One is billing for services, like our CSBs billing for all services that they could be billing for. And we have indications that they're not consistently doing that. And we have a recommendation there to make sure that we understand the extent to which they are just choosing not to, and partly because of the complexity, the increased complexity of having 6 MCOs that they have to work with. So we have a recommendation in there to have DBHDS work with DMAS and the MCOs to help to first identify which CSBs are not billing for Medicaid services to the extent they could be, but also providing them technical assistance to help them develop those capabilities. And the second bucket is being successful in getting your billing, getting Medicaid reimbursements from the MCOs. We have a couple recommendations in the report that could help streamline that process to help it be less complex. One is aligning the requirements across MCOs to the maximum extent we can, understanding there are some limitations there. But things like credentialing, centralizing credentialing so that CSB providers don't have to be credentialed with each of the MCOs, that could help. The last one I would point out is making sure that CSBs are aware of what they call preferred provider programs or gold card programs, which it doesn't require prior authorizations. So it's just a little less complex, but just making sure that CSBs are aware of what MCOs offer those programs for which type of services. And so that's happy to answer any questions though. That's a quick summary.
Anyone else? Yes.
Madam Chair, did you all look at a local share on a per capita basis for each locality within the CSBs?
Delegate Austin, we did. We looked at that, and we can provide information on that if you'd like. There is significant variation, but.
Yeah, I would like that, please. Thank you, Madam Chair.
You bet. Okay. Governor Youngkin has indicated that mental health services will be a priority of his. Mental health services are going to be my top priority. And Chairman Knight has indicated he feels that there is definitely more funding needed. So I think this report is amazingly timely and is going to be very useful in guiding our discussions and decisions. So thank you to the whole JLARC for working so hard on this.
Madam Chair, thank you very much. Turn it over to Commissioner Smith.
Yes. Good morning.
Morning, Madam Chair, members of the commission. Thank you for having me here. Mr. Greer, thank you and your team for working with our agency. The report couldn't be more timely. We appreciate the comprehensive analysis and hard work of the staff of JLARC to provide these recommendations. We believe this report reflects a comprehensive review of the CSB behavioral health system. It also provides elements of a larger roadmap to move Virginia's complex system forward. Of note, in the months that JLARC was developing this report, DBHDS was developing our North Star strategic plan with the overall goals of strengthening the workforce, expanding the comprehensive continuum of care, and modernizing our systems and processes. To be clear, this is DBHDS's strategic plan and not the governor's, to be confused with the governor's plan, which will be coming soon. Overall, the recommendations for DBHDS in the JLARC report were very consistent with DBHDS's North Star plan. And we are going to take these recommendations and integrate them into our plan as we're continuing to move forward in executing and delivering to our citizens. These include further developments of the crisis continuum, quality oversight of the pre-screening process, implementation of the data exchange system between CSBs and DBHDS, and increased oversight of workforce initiatives, such as salary increases. We're happy that you recognize the importance of building out the crisis system, but we want to emphasize that we have a lot more work to do. It needs to be built as a whole. When the system is fully built, there's a national model called Crisis Now, shows that 80% of the calls to 988 will be resolved on the phone. And for the remaining 20% of people who need intervention, our mobile crisis teams can respond to them in their communities. And then approximately 70% of them will actually need some sort of physical place to go. So you can see as this builds, our Virginians will be able to get the care they need when they need it. And we're focused on continuing this build-out. We believe that many of these recommendations at their core are more about quality management in the behavioral health system. As part of the Department of Justice Settlement Agreement, we have built out a quality management system on the developmental disabilities side of the house, and we agree that we need to build out the same thing for our behavioral health system. We agree with the recommendations regarding quality oversight and have taken preliminary actions consistent with the idea of improved quality oversight, performance monitoring, and shifting to measured outcomes instead of just outputs in our system. But much of our work in this area has had another facet, which increasing flexibility in how state funds are spent. In other words, restricted funding limits a successful shift in measuring outcomes that truly matter. Not just output, but outcomes. Are people truly getting better? We believe that to address this issue highlighted in this report, Virginia needs a single unifying model for the oversight and funding of CSBs. As such, the significant opportunities Virginia could harness through the Federal Certified Community Behavioral Health Clinic, or CCBHC's model, it deserves a mention today. CCBHCs are specifically designed clinics that provide comprehensive arrays of services of mental health and substance abuse for children and adults. The hallmark features of the CCBHC model includes, which is regardless of their ability to pay or their insurance status, is an array of services of 9 core services accompanied by a robust data outcome reporting system, quality benchmarks, and associated incentive payments, and a prospective payment model. Virginia is well positioned for this effort because we purposely built out the STEP Virginia array of services on the model of the CCBHC. And thanks to the General Assembly, each of the STEP has received the initial fundings as of last summer. The next steps are around data and outcomes, incentive payments, and prospective payment system. We believe that the CCBHC model provides a coordinated and comprehensive roadmap for addressing the JLARC recommendations surrounding the relationships between the CSBs, managed care companies, and DBHDS quality oversight of the CSBs. The CCBHC model and the strategic goals set forth in the North Star Plan will allow Virginia to make meaningful improvements while ensuring we are aligned with the governor's plan to improve the system, which is due to the General Assembly soon. Again, thank you for the opportunity to comment on this report. We look forward to continue our partnership in the advancement of the behavioral health services and the system in the Commonwealth.
Thank you, Commissioner.
Thank you.
Thank you.
Madam Chair, second item this morning will be fairly brief, but an update on a critically important topic. We wanted to remind you that we have a large review underway of the state's K-12 funding formula. We'll release our final report next summer after what will have been an 18-month review. The K-12 funding formula determines how much operational funding school divisions get to educate the state's 1.2 million students. We're looking at each part of the formula, which leads to an examination of some core questions about K through 12 operations. For example, should a division receive enough funding for one teacher for every 30 students or one teacher for every 25? Given the importance of the formula and the potential recommendations for your consideration that we are likely to have, recommendations with significant implications if you decide to implement them, we think it would be useful for the General Assembly to begin thinking now about a structured process to consider and evaluate proposed changes that are likely to come from this work. Some other states have used a deliberate and structured process when considering changes to their K through 12 funding formulas. They've thought ahead about how they would incorporate the perspective of the executive branch and the Board of Education, and how they would receive input from other key stakeholders at the local level. I'd be remiss if I didn't thank Superintendent Balo's staff, especially in their budget office. They've been extremely generous with their knowledge and time already on this project. I want to thank them for that and for their continued assistance moving into next year. Justin Brown is overseeing this work, and Mark Gribben is the project leader for this review, and Mark will provide you with an update. Mark?
Good morning, Madam Chair, members of the Commission. Before we get started, I'd like to acknowledge our study team for their continuing hard work, and I'd also like to thank VDOE for all of their help so far. We were directed by the 2021 General Assembly to look at public education funding. That includes the cost of education, how it's funded through the standards of quality, or SOQs, changes to the SOQs since 2009, and options for further changes going forward. The last time JLARC looked at education funding was back in 2002. I'll start off with a little background. Public education is one of the largest funding obligations for both state and local governments. On aggregate, Virginia's school divisions received $20.1 billion in funding in fiscal 21, a slight majority of which came from local sources. State laws set the framework for K-12 funding. The Virginia Constitution establishes the public education system and directs the General Assembly to determine how to fund it. Funding is supposed to be enough to meet prescribed standards of quality. Those standards are established in state laws and regulations, and the code also states that the quality of education depends on having appropriate salaries, benefits, and other resources. The General Assembly plays a key role in determining K-12 funding. The main way it does this is by setting the SOQ requirements, which determine both state and local SOQ funding obligations. The General Assembly also appropriates additional non-SOQ funds for specific purposes, like helping at-risk students and reducing class sizes. Virginia's K-12 funding approach was set up in the 70s, and the last comprehensive changes to that basic approach were made in the 80s. While there have been many piecemeal changes since then, the fundamental funding approach remains the same. And while we are looking at all funding, our main focus is on the SOQ funding, which accounts for most state funds and a substantial portion of those local funds. SOQ funding is determined in two steps. First, the total SOQ funding obligation for each division is calculated using the state's staffing standards and SOQ formula. Second, the state and local shares are determined using the Local Composite Index, or LCI. In fiscal 21, the SOQs required $6.6 billion from the state in sales taxes and $3.9 billion from locals. That ended up being a little over half of the total funding that school divisions received that year. At the end of the day, Virginia school divisions can receive substantially different amounts of funding depending on the totals they get from the state, their local governments, and the feds. You can see the range of division funding reflected here, with some divisions spending twice as much per student as others. And next, I'll give you a quick rundown of our research efforts. The long and the short of this slide is that we have been pursuing many different research tasks, from talking with educators and experts to a lot of data analysis. The work we're doing is in line with studies of education funding that have been done in other states. One of the main issues we're looking at is state staffing standards. These standards help decide funding, and so we want to know if they reflect actual and best practices. To that end, we've been holding a series of virtual work groups with Virginia educators to better understand school staffing needs. We'll then compare the current standards to work group recommendations, what the research literature recommends, and the actual staffing standards data from VDOE. Oh, excuse me, the actual staffing data from VDOE. We're also looking at the SOQ formula to see if it accurately estimates the cost of education. That means evaluating and reviewing all parts of the formula, including the support cap and other past changes. And per past precedent, the criteria we're using is that the formula should not be arbitrary and should reflect prevailing costs. We're also recreating the complex SOQ funding model internally at JLARC so that we can model potential changes to that formula. Next, we're looking at how the state determines local ability to pay and divides up state and local funding obligations. This involves an assessment of the Local Composite Index, or LCI, and identifying ways it could be improved or replaced. In addition to looking at issues with the current funding structure, we've also been directed to look at the basic question of whether school divisions receive enough funding. To that end, we're looking at historical changes in K-12 funding and spending. We're also comparing Virginia's school division funding to a few commonly used funding benchmarks, as well as other states. We'll also examine the relationship between funding, school quality, and student outcomes. Finally, we'll take everything we've learned and identify potential ways the state could improve its K-12 funding approach. We'll model how any proposed changes would affect state and local funding obligations, as well as the amount of funding received by each individual school division. The last couple slides here are on our next steps. We will present the final report to you next year at the June JLARC meeting. That report will include recommendations and options for changing the complex system of K-12 funding. Depending on what the General Assembly wants to pursue, substantial changes to the Code and Appropriation Act language could be considered, and there could also be significant budget implications. As Hal mentioned, given the potential changes that will be put forward for discussion, the General Assembly may want to decide how it will consider report findings in advance of the 2024 session. We'd also anticipate that many stakeholders will want to weigh in on any potential changes. Obviously, the administration, the Board of Education, and VDOE would be at the top of that list. Several other stakeholders will also be interested, including school divisions, local governments, education associations, and advocacy groups. We've identified a couple of options for you to consider for discussing any changes. One route might be to work through the existing education and budget committees. Another route could be forming a joint subcommittee on the K-12 formula, which I believe has existed in the past. But of course, there may be other routes that you think are preferable. And again, the idea here is to have some form for discussion of potential K-12 funding changes before the 2024 session, assuming that's a route that the legislature is interested in. Madam Chair, that concludes my presentation. Happy for any questions you or the members may have.
Questions? Well, thank you for the update, and we're going to look forward to the final report and the challenging implications of whatever it may be.
Thank you, Madam Chair.
Madam Chair, next on the agenda is dual enrollment. In the 2017 JLARC review of the community college system, we recommended that the state determine the true cost of dual enrollment. There were two separate attempts to do so since 2017, and neither was successful. However, working with data provided by 78 individual school divisions and all 23 community colleges, we were able to report to you this morning the true cost of dual enrollment. And given the cost relative to the funds appropriated for it by the General Assembly, there does not appear to be basis for continuing to charge tuition and fees to any high school student, especially any economically disadvantaged student who decides to further their education by taking dual enrollment courses. I want to thank the community college presidents and their staff for their efforts to provide us with the data needed, as well as the numerous school divisions for their substantial assistance with this review. Tracy Smith oversaw the study, and Lauren Excel was the project leader. I'd like to introduce Lauren. Lauren?
Thank you, Hal. Good morning, Madam Chair, members of the Commission. As Hal mentioned, I was the project leader for our dual enrollment cost study. Before Brittany, our team's lead analyst, shares our dual enrollment findings and recommendations with you this morning, I wanted to share a few pieces of information to keep in mind. First, we know there's been a lot of interest in dual enrollment lately, including discussions about expanding the program. We hope our work will inform these ongoing discussions, but I wanted to remind the Commission that our research was primarily an assessment of the dual enrollment cost structure. We did not assess the quality or outcomes of dual enrollment because that was covered in JLARC's 2017 review of the community college system, and it's too early to fully assess the changes that were recently implemented in this area. The second point I want to make is that dual enrollment is offered in a few different ways in Virginia, but over 90% of students take dual enrollment in high school classrooms through credentialed high school teachers. A relatively small number of students take dual enrollment at community colleges or at the public four-year institutions when courses aren't available through the community colleges. Importantly, our findings and recommendations all focus on dual enrollment taught at high schools because that's where the bulk of the dual enrollment is happening and where the costs are the most varied. And the last thing I'll say, Madam Chair, is that we're going to share several recommendations and policy options with you this morning that would change the way dual enrollment is funded. We feel strongly that our proposed changes would make dual enrollment more accessible and affordable for students. You may hear that some of our changes would disincentivize community colleges from offering dual enrollment, but we've structured our recommendations and policy options so that if they're implemented together, there would not be a revenue reduction for colleges. In fact, dual enrollment demand is likely to increase because students would no longer pay for dual enrollment offered on high school campuses. The state would also have greater transparency into colleges and school divisions' dual enrollment revenues and expenses. These have been cited as key priorities in recent years. Now, Madam Chair, I'd like to introduce Brittany Utz, the lead analyst for our dual enrollment cost study. Brittany?
Good morning, Madam Chair and members of the Commission. As Lauren said, my name is Brittany Utz, and I was the lead analyst on our dual enrollment cost study this year. I would like to thank the leadership and staff at the community colleges and school divisions that provided us with financial data on their dual enrollment programs, as well as staff from VCCS and VDOE for their assistance with this review. JLARC staff were directed to determine the cost to provide dual enrollment courses as part of the study resolution on higher education student financial aid, but are reporting the results of this review separately from the financial aid report. Slide 3 lists our primary research activities for this study. I won't cover these in detail, but I did want to mention one key aspect of our research, which was to survey community colleges and school divisions to collect financial data on their dual enrollment programs. We received responses from all 23 community colleges and 78 school divisions. More information about this data collection effort can be found in Appendix B of the report. We also spoke with a number of colleges and school divisions to better understand how potential changes to the funding model would impact their dual enrollment programs. To briefly summarize our research, we found that dual enrollment expenses consist primarily of personnel costs and are nearly 5 times greater for school divisions than community colleges. All community colleges and the vast majority of school divisions have sufficient state and local funding to cover their dual enrollment expenses. High school students in the majority of school divisions do not pay for dual enrollment courses. And finally, community colleges and school divisions should no longer charge dual enrollment tuition or fees for courses provided on the high school campus. My presentation today has 3 sections to highlight some of our key findings and recommendations. However, we have much more information on these and additional topics in the final report, including an appendix on AP costs, which was a topic of interest to members during our work plan meeting earlier this year. First, to provide some background, dual enrollment allows high school students to earn both high school and college credit by taking college-level courses, which may help students save on higher education costs by reducing the time and cost of attaining a post-secondary credential. The number of students participating in dual enrollment has grown over the past decade, from over 27,000 students in the 2012-13 academic year to over 42,000 students in 2021-22. Most courses are provided at the high school, in which school divisions provide classroom space and credentialed teachers, and community colleges provide course oversight. Dual enrollment students represented 17% of total community college enrollment in 2021-22. However, at several colleges, 1/3 or more of their enrollment is made up of dual enrollment students. Total dual enrollment expenses are split among community colleges, school divisions, and students. First, community colleges incur expenses to provide dual enrollment, then determine whether to charge per credit hour dual enrollment tuition and fees to school divisions. In addition to tuition and fees paid to the colleges, school divisions incur their own expenses to operate dual enrollment programs and determine whether to charge students to cover these costs. In divisions that decide to charge tuition and fees, dual enrollment students are responsible for paying these costs along with any other course-related expenses not covered by the division. For both colleges and school divisions, most dual enrollment expenses would be incurred regardless of whether dual enrollment is offered. However, to estimate the total cost of dual enrollment, we included both expenses that are solely related to the provision of dual enrollment, as well as portions of expenses that would be incurred even without a dual enrollment program, such as college faculty and high school teacher salaries. We first looked at the costs incurred by community colleges to provide dual enrollment, the extent to which colleges have sufficient revenue to cover these costs, and how these costs are passed on to school divisions. We found that community colleges' dual enrollment costs are about $59 per credit hour on average. We also found that community colleges have substantially more state funds than needed to cover their dual enrollment expenses, but that most colleges still charge school divisions dual enrollment tuition and fees. Slide 9 shows a breakdown of average community college dual enrollment related expenses. Over 95% of colleges' expenses are related to personnel. For example, colleges typically have one or more dual enrollment coordinators who are responsible for day-to-day administration of their dual enrollment programs. Colleges also incurred materials and other programmatic expenses to provide dual enrollment courses, such as printing and advertising materials to market the program. The teal dots at the bottom of the figure show each community college's per credit hour dual enrollment expenses. As you can see, most colleges' expenses are clustered between $20 and $80 per credit hour. Based on the expenses reported by each of the community colleges, all colleges have enough state general funds to cover their dual enrollment expenses. Colleges receive state general funds to cover their dual enrollment expenses based on their number of full-time equivalent dual enrollment students. For the 2021-22 academic year, colleges received an average of $2.2 million in state general funds for their dual enrollment FTEs and had an average of 73% remaining after accounting for their dual enrollment expenses. Despite colleges having sufficient state general funds to cover their dual enrollment expenses, 21 out of 23 community colleges still charge dual enrollment tuition and/or fees to the school divisions in their service regions. The various rates charged by colleges are shown here on the map. Across the colleges that charge tuition and/or fees for dual enrollment courses, the average rate is around $24 per credit hour. Colleges use their surplus dual enrollment revenue, which averaged $1.7 million in 2021-22, to subsidize other aspects of their operations. Several colleges report using this revenue to subsidize their CTE courses, which are expensive to offer because of small class sizes, specialized faculty, and expensive equipment. For example, one college reported that direct instructional expenses are about $15,000 per FTE for its nursing program and about $7,000 per FTE for its welding program, in comparison to about $1,000 per dual enrollment FTE. Colleges report using the surplus revenue from their dual enrollment FTEs to help cover expenses for these higher cost programs. Before I turn to our findings on school divisions, I'll pause here to see if anyone has questions at this point.
Questions?
Okay. We next looked at costs incurred by school divisions to provide dual enrollment and the extent to which divisions have sufficient revenue to cover these costs. We found that school divisions' dual enrollment costs are about $276 per credit hour on average. We also found that the vast majority of school divisions are estimated to have enough state and local funding to cover their dual enrollment expenses. Slide 14 shows a breakdown of average school division dual enrollment related operating expenses. Expenses incurred by school divisions are generally higher than community colleges' expenses because of dual enrollment teacher salary costs. School divisions also incurred some materials and other programmatic expenses for dual enrollment, such as course textbooks. The teal dots at the bottom of the figure show each school division's per credit hour dual enrollment expenses. Most divisions' expenses are clustered between $100 and $500 per credit hour. Based on these reported expenses, the vast majority of school divisions have enough state and local funding to cover their dual enrollment expenses. School divisions receive state general funds based on their average daily membership, in which dual enrollment students are counted the same as other students. Of the 69 divisions for which information was available, 65 had enough state and local funding to cover their dual enrollment expenses. Finally, we looked at whether and how school divisions' dual enrollment costs are passed on to their dual enrollment students. We found that students in the majority of school divisions, as well as the majority of students across those divisions, do not pay for dual enrollment courses. Students don't pay for dual enrollment courses in 58% of the school divisions for which information was available. Students may not have to pay tuition and fees if their school division is in a service region in which the community college doesn't charge tuition or fees, or if their school division absorbs these costs and does not pass them on to students. In the divisions that do charge students to take dual enrollment courses, divisions may charge a lower rate than the community college so that students only pay a partial cost or charge students the full cost. The map on slide 18 shows how tuition and fee rates paid by students for dual enrollment courses vary across the state. In the divisions that do charge, students pay an average of about $34 per credit hour. This amounts to around $300 for an average course load of three credit hour courses per year. Madam Chair, I know that's a lot of information to absorb, so I'll pause again here in case any members have questions.
Don't see any.
Okay. I will now turn to our proposed changes to the state's dual enrollment funding model. First, because colleges and the vast majority of school divisions' dual enrollment expenses are sufficiently covered by state and local funds, we propose eliminating dual enrollment tuition and fees for courses taught on high school campuses. Eliminating tuition and fees would make student access to dual enrollment more consistent across the state and would particularly improve access for economically disadvantaged students. Economically disadvantaged students have the lowest participation rates on average in dual enrollment programs that have higher tuition and fees. Eliminating tuition and fees would remove this financial barrier and make dual enrollment courses more accessible for these students. This change would also generally help school divisions, which would save an average of $81,000 per year in tuition and fees that they would no longer pay to the colleges. However, there are a few divisions that would lose revenue as a result of this change because they are charging students a higher tuition rate than the community college rate to cover a portion of their own expenses. Eliminating dual enrollment tuition and fees would also reduce community college revenue by an average of $270,000 per year. Slide 21 lists our recommendation to eliminate dual enrollment tuition and fees. We also have two policy options listed on this slide to provide additional funding to colleges and school divisions to make up for the revenue they would lose by no longer charging tuition and fees. Specifically for the community colleges, this policy option would include an appropriation of an additional $6.2 million to VCCS's base budget to replace colleges' foregone tuition and fee revenue. Should the General Assembly decide not to eliminate tuition and fees for all students statewide, we have additional recommendations in the report that would, at a minimum, ensure dual enrollment courses are provided at no cost to economically disadvantaged students, including tuition and fee costs, as well as textbooks and other course supplies for these students. More information about these recommendations and policy options can can be found in chapters 3 and 4 of the report. Additionally, the state general funds that community colleges receive for dual enrollment are not based on actual program expenses. VCCS does not receive state funding appropriated specifically for dual enrollment. The General Assembly appropriates a total general fund amount to VCCS, which VCCS then distributes to individual colleges to cover their dual enrollment and non-dual enrollment expenses. VCCS's internal formula used to distribute general funds to the colleges treats dual enrollment students the same as traditional students, which does not tie funding amounts for dual enrollment to colleges' actual expenses to support these students. Distributing general funds to colleges for their dual enrollment programs based on actual expenses would help to clarify both the colleges and the state's dual enrollment costs. We have a few recommendations that would address these concerns and would help to make dual enrollment costs more transparent, which are to include language in the Appropriation Act to specify the amount appropriated to VCCS for dual enrollment, to direct VCCS to develop and implement a process to distribute general funds to colleges for dual enrollment based on colleges' actual expenses, and to direct community colleges to document and track financial data related to their dual enrollment programs. We have additional details about each of these recommendations in Chapter 4 of the report. Finally, colleges currently receive about $38 million more in general funds than needed to operate their dual enrollment programs, which they use to subsidize other expenses. At some colleges, particularly those with a large proportion of dual enrollment students, this surplus revenue represents up to 10% of total college revenue. Some stakeholders have expressed concern that by separating dual enrollment funding from other funding, colleges could lose this revenue, which college leaders reported would be detrimental to their operations. However, the total amount of general funds colleges receive would not need to change by implementing the recommendations in our report. To reflect this, we have a policy option in which the General Assembly could continue to use the same methodology for determining the amount to appropriate to VCCS, which would maintain community colleges' funding levels, avoid negative impacts on colleges' operations, and would not be a new cost to the state. Madam Chair, I'll pause here in case any members have questions. Okay. I will now briefly cover our findings on dual enrollment teacher credentialing. Our study was primarily focused on dual enrollment costs. However, in speaking with school divisions, a lack of credentialed teachers was consistently cited as divisions' most common concern about their ability to offer dual enrollment. So we conducted some additional research on this topic to include in our final report. We found that the lack of credentialed dual enrollment teachers generally stems from two factors. First, the time and cost of becoming qualified deters high school teachers from pursuing these credentials. Additionally, after they obtain the necessary credentials, teachers in most divisions don't receive any compensation for the additional workload associated with teaching dual enrollment courses. Chapter 2 of our report outlines several approaches the state could consider to alleviate the shortage of dual enrollment teachers, two of which are listed here on this slide. The General Assembly could appropriate funding to provide bonuses to high school dual enrollment teachers and/or appropriate funding to pay college faculty to teach dual enrollment courses at high schools. We present these two as policy options rather than recommendations because the effectiveness of each approach is likely to vary across school divisions. Both approaches are likely needed to meaningfully improve the dual enrollment teacher shortage. I won't read these for you, but slide 29 summarizes our key findings. And that, Madam Chair, concludes my presentation. I would be happy to answer any questions.
Thank you. Questions?
Madam Chair, I have a question.
Yes. Senator Locke.
But my question doesn't really have to do with what you were talking about in terms of funding. I've been getting questions from parents more to do with what actually transfers, and I know that your study doesn't have to do with that, but if at some point JLARC could actually look at what transfers, because parents are concerned that the kids are taking these courses, and they're taking a lot of these courses, and sometimes these courses do not transfer, and that is a concern.
Yes, Senator Locke, that's a good question. We do have a little bit of information in Chapter 1 about this. Initially, when JLARC did our 2017 study of VCCS, we found exactly that you're talking about, that there were issues with transferability and that the four-year institutions were reluctant to accept those course credits. And so out of that, the General Assembly created the Passport and Uniform Certificate of General Studies programs. And so those have been implemented, and the first set of those credentials were just awarded this spring. So we did not specifically evaluate the outcomes of those programs because they're so new. However, I will say that when we spoke to stakeholders at community colleges and school divisions, that the feedback on those programs was generally very positive, that they believe that they'll have a positive impact on the transferability of dual enrollment courses. And then also out of that, the Transfer Virginia portal was created by Chev, where parents and students can go online to look at how courses they take will transfer to different institutions. And then also, we didn't cover this today, but we do have a recommendation in the report for Chev to have a position to oversee the state's dual enrollment program, which there's not currently a position at any state agency that does that. But as part of that responsibility, one of the things that we think Chev could do is to evaluate whether and how courses are being transferred across institutions.
Thank you. Thank you.
Madam Chair.
Yes, Senator McPike.
Thank you, Madam Chair. I had a couple quick questions. One of which is the caveat that this report does not include CTE dual enrollment.
Correct.
Is that right? Mm-hmm. So anything that has certificate programs, nursing, welding, the rest of it, that's excluded from the cost models.
Correct. However, I will say that it's my understanding that most CTE courses that are provided through the community colleges are taken on the college campus. And so that's a little bit, part of the reason why we didn't look at those is because it's a different funding model, because students currently pay full tuition and fees to take courses on the community college campus, because they're treated the same as a traditional student at that point, and the community college is providing all of the resources for that. So I would say that any interest in CTE, I would look at, in particular, how to reduce the amount that students are paying to take courses on the college campus.
Okay. If I'll,
Yes.
Slide 18, I think it was probably what really instigated a lot of our questions from a JLARC perspective, where we heard from constituents that some groups were getting charged different rates. Kind of made no sense to a lot of us to sort of dig in to start to study this. In the cost recommendations, you backfill and recommend $6.2 million across those that charge. I'm a little confused. The top one, for instance, has charges $1.3 million, and then in the follow-up table on 4.2, you have a list of sort of balance remaining after expenses, and even for that one, they still had $3 million left over. Can you help differentiate and walk me through the math on that one?
Yes.
If we're recommending appropriations of 6.2, but yet there's backfill, I understand there's overhead, or there's probably some other sunk costs. Help me understand those.
Yes. So the way that community colleges are currently funding their dual enrollment programs is that they receive general funds from the state for their dual enrollment full-time equivalent students. And so what you'll see in Table 4.2 is the amount of general funds that they have remaining after their dual enrollment expenses are covered. What that doesn't include, and where the $6.2 million comes in, is any additional revenue that colleges are collecting in dual enrollment tuition and fees. So the $6.2 million is the amount in total that colleges are collecting in their dual enrollment tuition and fees, which they would no longer have if the state eliminated that. But then the Table 4.2 includes the remaining general funds that they have left over. So it's basically a difference between the general funds in Table 4.2 and the tuition and fee revenue in Table 4.1.
Delegate Austin.
Thank you, Madam Chair. Madam Chair, I would just add that I'm happy to see this report. I've had concerns addressed to me from constituents over the years, and it's really nice to see that we should be able to bring some parity and some closure and to provide to everyone. The people that are suffering the most are the students who don't have the ability, their parents do not have the ability to pay, and they should not be affected in that way in the Commonwealth. So thank you, Madam Chair.
And thank you for your comment. I agree with it. Okay. Thank you.
Thank you.
I believe Secretary Gadara is next. Yes, and I did think I saw you out there.
Good morning,
Good
Madam
morning.
Chairwoman and
morning.
members of the committee, and happy holidays to you all. Sorry, I was trying to sneak in the back door. It turns out it's exit only. It's nice to be back with you all again, and I agree with the last comments that this report is really interesting and thought-provoking. And I want to thank to Director Greer and the great team that put this report together. They came and met with our team, and we've been having nonstop conversations since, and across with the community colleges, with SHEV, and with the K-12. And so that's a sign to me of a great report when it causes more conversation, lots of questions, and lots of issues to talk about. And we very much look forward to continuing those conversations with all of you in the General Assembly as well. And as you know, we share the General Assembly's commitment in the Youngkin administration to ensuring that we expand opportunities so that there are no ceilings for our students in K-12. That means access to advanced coursework if it's not available in their K-12 school, but also access to industry-recognized credentials and exposure to careers. And as you know, that's something we believe deeply about, and we want to do everything possible to tighten the connection between what happens in our K-12 schools and what happens beyond the walls of schools to make learning come alive, to get our students exposed to the world of work, to have them have experiences, and to gain some expertise. And we think the conversation about access to advanced coursework and also access to credentials that are different than advanced coursework start to open doors to new opportunities are something that we're very much interested in expanding and working together with the General Assembly to do that. This report, and I just want to have a couple moments to share some of the conversations we've been having and where we think that we want to go back and get some more information to inform decisions, because as you have most likely heard, and we'll hear more on Thursday, this governor is all about expanding those opportunities and thinking differently about how we think about high school and that connection point to post-secondary education and training. But to do that and to be best in class, we need to study what's happening around the country, and we also need to use data and evidence to make sure that we're making the best decisions that are both efficient and effective and are using the taxpayer dollars well. And so a couple things that come up when we're thinking about this, and I again want to thank JLARC for doing such a great job of putting this all out there for us to have continued conversations. First of all, just the costs. We think that this raises the conversation, Senator Pike, as you just brought up, the difference between the cost of access to dual enrollment and the cost of industry-recognized credentials and workplace skilled pieces. And we want to get a better understanding of what both of those cost. We also want to have a better understanding of what the cost that is to provide if it's happening on college campuses or if it's happening in the K-12 classroom. But we also started having conversations about the other benefits that could happen potentially when learning happens, when exposure to skills and advanced coursework happens on a college campus. For example, when a student is the first in their family to think about going to college, the concept of going and stepping foot on a campus, whether it be a 2 or 4 year, can be transformative in terms of opening doors, thinking about what's possible, seeing people like them and saying, I can do this too, which is different than when you're going next door to Mrs. Smith's classroom to get the same information. And so we have started to look into national research to see if there's research saying what is different when students actually have this exposure to post-secondary work on a college campus. And so we're having conversations about that, and we'll continue our conversations with the great team at JLARC as well, who also is looking into that. And then just more on data, just more of an understanding of how many students, what is the breakdown about students having exposure in classrooms, in college campuses, the differences between how many of our students are actually going after those industry-recognized credentials. So we're hungry for that data. We look forward to working with you. We will share with you whatever we learn, and we'll be working with JLARC. And then I also think that there's some changes that we need to use with language. You know, we're using the term dual enrollment, and it's confusing, and we kept having conversations on our team that dual enrollment means so many different things to different people. Is it going to school in someplace else? Is it going to school in your high school? And does it mean getting skills, a credential, or getting an advanced degree? And so part of what we're also going to be talking about is how do we change the language so we can be much more clear about what we're talking about. Bottom line, what I'll say in terms of the other conversations that aren't as many about additional data as it is about where we want to go with this, is that we feel it's important, and the recommendations start to get to this, to make sure that we are incentivize all the stakeholders to be working together to expand the opportunities for our students and for all of our students to have the opportunity to do this. And so means how do we make sure that the community college system is excited about expanding their options to have K-12 students working with them, to also have exposure to make sure K-12 systems want to do this, and especially to make sure that every family understands that this is an opportunity that's open for them and for their children. Bottom line is, we're really excited to dive deeper into this work. We're looking forward to having more data, getting more evidence, and working together with the General Assembly to make sure that this concept of having access to advanced coursework and to credentials about workplace skills and knowledge and competencies are ones that we're working together with the General Assembly to put in place. And I'm happy to take any questions. Thank you, ma'am.
Are there questions? No, thank you very
Thank
much,
you.
Madam Secretary.
Thank you. Thank you so much.
Madam Chair, the next item on the agenda is VEC. As you recall, the Commission requested that we provide an update on VEC's progress toward addressing their backlogs and their challenges that they have faced. We've been working with the Commissioner Roth and her staff to get you the latest data on the Commission's progress, and want to thank them for their assistance. Lauren Exel, who is the project leader for our review of VEC, will provide you with an update. Lauren?
Hello again, Madam Chair, members of the Commission. As Hal mentioned, I'm Lauren Exel, and I was the project leader for JLARC's 2021 review of the Virginia Employment Commission. As you may remember, JLARC released a report on the VEC last November that had multiple findings on areas in need of improvement. We had 40 recommendations and 10 policy options to address issues we identified, over half of which have already been implemented through legislation or internally at the VEC. Despite this progress, though, at the October JLARC Study Topic Subcommittee meeting, members shared they are still being contacted by constituents about the VEC. In light of that, we are asked to provide an update. I'll spend the next few slides sharing the information we've collected on recent changes at the VEC and areas that are still experiencing challenges. The table on slide 3 provides a high-level overview of several of VEC's key functional areas, including the size and trends of their backlogs and whether staffing levels are sufficient. I'll provide more details about specific functions in later slides. But as you can see here, though, appeals is the largest pain point right now in terms of backlog size and staffing. VEC still has backlogs and claims awaiting a fraud investigation and adjudications, but the size of these backlogs has decreased significantly over the past year. And VEC's customer service, which is at the bottom of the table, is experiencing staffing as well as some other challenges. Performance in these areas isn't measured through backlogs, but I'll share some other metrics in just a few slides. Now I'll walk through a few slides with more information about VEC's appeals. As you saw in the previous table, VEC's backlog of UI claims awaiting first-level appeals is significant, but it's just started to decrease slightly, which is a step in the right direction. As a quick refresher, VEC has a 2-tiered system of appeals, and the first type of appeal that claimants and employers can file is called a first-level appeal. At the start of November, VEC's first-level appeals backlog was about 99,000. After oscillating a bit in November, the backlog has started to decrease slightly and was just under 98,000 as of December 4th. This isn't a huge decrease, but VEC leadership believe most of the pandemic-related appeals have now been filed, and they expect the backlog to continue to decrease going forward. The figure on slide 6 shows the timeliness of VEC's first-level appeals, and the takeaway here is that VEC is still taking much longer than the U.S. average to resolve first-level appeals. At the end of September, VEC's first-level appeals were taking 307 days to resolve on average, compared to the U.S. average of 218 days. Both of these averages are significantly higher than DOL standard, which is shown at the bottom with the dotted teal line. The legislature and VEC have made several changes to date to help address the first-level appeals backlog. Legislation, co-patroned by several JLARC members, clarified in statute that certain types of claims are ineligible for appeal before other steps in the claims process are completed. VEC leadership have also made a number of changes, including revising appeals letters to claimants to reduce invalid appeals, using adjudication staff to help on the front and back end of appeals, increasing appeal staff salary, and hiring 30 new staff, to name a few. There are a few other items on this slide as well. Going forward, the large volume of appeals filed and the appeal staffing levels are the biggest challenges preventing VEC from eliminating the first level appeals backlog in the near term. Since the start of the year, VEC has received over 82,000 appeals, many of which were filed when claims previously stuck in adjudication were resolved. VEC is also still working to fill some appeal staff positions to help resolve outstanding appeals. VEC has 7 vacant appeals examiner positions that staff have been trying to fill, but agency leadership shared it's been challenging to recruit qualified individuals even after increasing the salary offered. In addition, many appeal staff positions could be eliminated over the next few months. 37 appeals positions are set to expire next June unless additional funding is improved. VEC is also losing 55 contractors next year who have been assisting with appeals, but the agency plans to use VEC staff from other areas to help support appeals. VEC leadership currently expect the first level appeals backlog to be resolved by November of next year. Madam Chair, I'll pause here for any questions.
I don't see any.
Okay, now I'll spend some time discussing the status of VEC's IT system and call centers, which are the primary ways that VEC interacts with its customers. We know members have raised concern about claimants being unable to access VEC's new UI benefits system, and recent data shows that many claimant attempts to log into the system have been unsuccessful. The system was launched last November to automate VEC's previously manual and inefficient claims process. In October, over half of claimants' attempts to use the system failed, in most cases because their usernames couldn't be found or they had incorrect passwords. About half of the failed logins were resolved with password resets, but the other half required additional action from VEC because of suspected fraud. The UI system has also been down 39 times that were not planned since the beginning of the year. Unplanned downtime totaled over 3 days and averaged about 2 hours per occurrence. Challenges with VEC's UI system have a ripple effect on their call center workload, and they're partially driven by staffing levels. VEC's goal is to serve the majority of claimants online to increase efficiency, but when claimants can't access the UI system to do things like file their weekly claims, they call VEC's call center to file their claims by phone, which increases the call volume. To effectively maintain and update the system, it's important for VEC staff to have sufficient IT staff. According to VEC, they've advertised all of their IT programmer position vacancies, but it's been difficult to attract qualified individuals to these positions. They have filled several vacancies over the past year, but still have 8 that are unfilled. Finding IT programmers is a common challenge across state agencies. VEC has taken steps to improve their recruiting success, such as hiring a private recruiter to review their job posting and increasing the salary offered. Now focusing on VEC's call center performance, many claimants had difficulty reaching VEC in October, but call center accessibility improved significantly in November. About 90,000 calls made to VEC's call center where someone was trying to reach an employee were flagged and deflected in October. These calls were not answered in accordance with VEC's policies, most commonly because caller information indicated potential fraud. A much smaller portion of callers were flagged and deflected because they called more than twice in a day. As of November, only about 3,000 calls were flagged and deflected, which was a 97% decrease. And also in November, nearly 71,000 calls were successfully answered, and the average call wait time was about 7 minutes. According to VEC leadership, call center staffing and performance may get worse over the next few months after the call center contractor leaves, especially if claims increase. VEC had 149 agency staff and 75 contractors answering calls in November. 55 of the agency staff answering calls are in temporary positions that expire next June. VEC's call center contractor just finished transitioning out last Friday, which means VEC now has 75 fewer staff answering calls. In anticipation of this, VEC has been hiring wage employees to help offset staffing losses, but even with these new wage staff hires, VEC expects longer call wait times for the next few months. Seasonal layoffs and poor economic conditions could add further strain to the call center performance. Madam Chair, I'll pause here.
Madam Chair.
Yes, Senator McPike.
Thank you, Madam Chair. I think that the numbers of 90,000 block calls and other things that we experienced from constituents were one of the key things that we asked for the update based on both the denial, the failure to log in. They would call from their home phone. It was blocked. They couldn't get any. They went to local office. They couldn't get help for like weeks. Were these individuals that were blocked for months able to backdate their claim? Because the way the system works is your claim has to be filed in order for them to get benefits. And it's only upon receipt of that that's the claims start. And so people missed out on weeks and weeks of benefits that they were due when they were laid off. Were you able to come across any of that data of whether they're actually able to go from when they were terminated?
Senator McPike, we didn't request that data specifically, but looking over at VEC staff, they should have been able to backdate their claims, yes.
Anyone else?
Okay. Madam Chair, my next few slides provide additional information about the status of VEC's claims awaiting fraud investigation, adjudication, and reviews of the employer separation reports. For the sake of the time, though, I won't go through them because the key takeaways are largely positive. The backlogs in these areas have decreased substantially or have been eliminated due to changes implemented by VEC and the legislature. I'll just click through a few of these. And I'll cover slide 18 here to wrap up. This last slide describes the new Unemployment Insurance Subcommittee that was created last session to oversee VEC's performance going forward. The subcommittee will monitor VEC's backlogs and correct benefit payments and IT system functionality, among other things. The subcommittee will meet at least 4 times a year for the next several years, and it'll report annually to several legislative committees. Madam Chair, I'll stop there, and I'd be happy to answer any questions.
Questions? Thank you. But you did explain why we were inundated again in September and October, I believe it was, with constituent dissatisfaction, to put it mildly. Thank you.
Thank you.
Madam Chair, next is our VRS Oversight Report. Jamie Bitts will present that. Jamie?
Good morning, Madam Chair. As Hal said, my name is Jamie Bitts, and I'll give you a very brief update or version of our semi-annual report and update on VRS. You've heard a number of presentations this morning, and so I'll actually just touch on a few key slides. Skipping to slide 4, as you may know, the financial assets used to pay VRS benefits are pooled in its trust fund, and a core responsibility of VRS is managing the investment of those assets. The trust fund had a return of negative 5% for the 1-year period ending on September 30th. But that did exceed the benchmark for that period, and VRS trust fund returns for all of the other time periods exceeded their benchmarks as well. Total assets in the trust fund declined for the year ending September 30th, but the decline would have been much larger if VRS had not exceeded those benchmarks. The table on slide 5 just shows you the total fund returns relative to those benchmarks, and so you can see that the returns were substantially better for every period, and in particular for the 1-year period. The returns also exceeded the long-term return assumption of 6.75% that the VRS board makes, exceeded that assumption for all but the one-year period. And this slide just shows you a breakdown of investment returns for the different asset classes. And so you can see that VRS exceeded all but one of its benchmarks across the different asset classes. Madam Chair, I'll skip to slide 9 and just talk for a moment about trust fund contribution rates and funded status. As you know, every 2 years, the VRS board certifies the employer contribution rates that are needed to fully fund the pension plans over time. The board certified rates decreased for the FY23-24 biennium. That was primarily because of the substantial investment returns from FY21. But the 2022 Appropriation Act did maintain the higher contribution rates from the previous biennium. And that could result in substantial savings for the pension plans, and in particular, for the teachers and state employees plans. The funded status of both of those plans increased in fiscal year 22. That was partly because of the substantial investment returns in FY21. Any asset gains or losses are phased in over 5 years, and so those substantial investment returns are still having a positive impact on the funded status. The funded status of those plans also increased because of actions taken by the General Assembly to pay down unfunded liabilities. And so to give you an example, in addition to maintaining the higher contribution rates for the current biennium, the Appropriation Act also included a total of $1 billion to further reduce unfunded liabilities. $750 million of that was provided to the plans in June of this year, and then the remaining $250 million will be, or is scheduled to be provided in June of next year, and that is, of course, assuming that general fund revenues meet expectations in the budget. And Madam Chair, that's everything that I wanted to make sure that we had time to cover, but I'm certainly happy to answer any questions that there may be.
Questions?
Thank you.
Apparently not, but it sounds like we should be patting ourselves on the back for what we did last year.
Yes.
Thank you.
Thank you, Madam Chair. And I'll introduce Kimberly Sarte, an Associate Director at JLARC.
Thank you, Jamie. Good morning, Madam Chair. As Jamie mentioned, I am JLARC's Associate Director for Ongoing Oversight and Fiscal Analysis. And as you know, JLARC conducts ongoing oversight in a variety of areas. There are a few items in your packet today on these areas, but due to the length of the agenda, we're not going to present them. However, I did want to give you some of the main takeaways. You have a report and slides on our annual review of the state's economic development incentives. This is an annual report, so not a lot has changed. However, it continues to make the point that grants have a higher economic benefit than tax incentives, even though the majority of the state's incentive spending is on tax incentives. You also have slides on our annual update of the Cardinal Human Capital Management IT project. This project, as you may recall, expanded on the Cardinal financial system to include payroll and HR. It was a very large project, but it was successfully completed in October. It was on budget and within the revised schedule that they had set for it, and it was up without any major incidents. There have been a few minor things they're working on, but nothing major. And finally, you have our annual report on the state portion of SOQ spending. In FY22, the state portion rose 2.5% to $6.8 billion. And that's everything, Madam Chair, that I wanted to point out. I'm happy to take any questions, but if there are none, I'll turn the meeting back over to Hal.
Are there questions? Hal, thank you.
Madam Chair, that concludes our meeting for today and includes our meetings for 2022. I want to thank you very much for your attention today. I want to wish you all a very happy holiday season and also let you know that we're available to provide assistance on any legislation that relates to any of our recommendations, please feel free just to reach out to us. Thank you very much.
Thank you. Thank you, and happy holidays to everyone from us as well. And if there's no further business, we stand adjourned.